I'm going to tell you about the other form of encephalitis, the autoimmune form, where your body's innate immune system reacts against the brain, and typically it does that with the production of autoantibodies, which actually go and target the brain tissue. And I'm going to talk you through three aspects of that, which I thought would illustrate the points in the way that I'm trying to bring together some of the research and some of the clinical observations to help patients in the future. So this is some very simple biology first. So autoimmune encephalitis we're going to get to as an entity which is caused by the autoantibodies themselves. The autoantibodies are made by plasma cells. So these are cells of your immune system. And they secrete these antibodies, which are these sort of upside down Y-shaped molecules. You may have heard of some of the targets. I've put two up there, but probably the commonest is the NMDA receptor antibody encephalitis. And so the sorts of questions we're asking are, how are the antibodies made? And that might be important in thinking about how they might be, how that production might be disrupted. We're wondering how they get into the brain, because they're made in the periphery, they're made in your blood. How do they get into the brain? So there's this entity called the blood-brain barrier, which something has to cross. It's either the cells that cross it, or it's the antibodies themselves, or both. And they access the brain, and then we're interested in which parts of the brain might be affected by this process, and then how the antibodies affect their target, and how all this might inform treatments. And that's really the important point that I'm going to get to. And I'm going to get to it using three examples. So three examples of how our current research is aiming to try and improve the future. So the first is to try and carefully and systematically understand what patients think are the main problems. Secondly, to try and more carefully tailor therapies for the future. And thirdly, one example of how the research may go about preventing some forms of encephalitis. So this is a modified ranking score. Some of you may have heard of this. It's a measure used in clinical studies to rate how badly or how well someone's doing. So you can see it starts off at the bottom there with no symptoms. 6 is where patients, where 6 is death due to the encephalopathy, and then everything else is a gradient in between. The most important thing is that at 1, it's said to be no significant disability, defined as all usual activities despite some symptoms. So you can imagine how that's a ragbag of entities there. And 2 is then defined as can look after your own affairs without assistance. So that's traditionally used in a number of studies to rate how well or badly someone's doing. And these are some of our data showing that patients start off with higher scores. On the whole, they improve over time. And that's the general dogma. Patients improve with therapies which suppress the immune system. So in an autoimmune encephalitis, you try and attack the immune system with the drugs to calm it down. But if you measure any one of these scores, and I've picked this score at 1 here, actually, if you go and ask patients, we asked 13 patients, what's actually left? What are the residual problems? There's a huge list of things. The sorts of things you've already heard about today. They're not novel in their own right. But actually, if you use this score over here, patients would be defined as being able to perform all their usual activities. And that may well be not be a fair representation of what's being seen. So another example of where some of the surprises have arisen when we look at patient outcomes. So these are 9 questions, and each patient is asked to rate them before and after their encephalitis. From the sorts of things we've already heard today, you might anticipate that the problems include life as a whole, perhaps family life, perhaps social interactions. And so that might have been the prediction before we started this sort of research. But what we found actually was the real standout here was question 6, which was sexual function. So actually many patients with this problem, with this illness, with this type of encephalitis, and it's one of the antibody-mediated encephalitides, were worse after the encephalitis, of course, and sexual function was a prominent feature. And in fact, this was related to high signal here, inflammation, due to the autoimmune problem, in the part of the brain called the amygdala, which sits just next to the hippocampus. And in fact, it's becoming clear that when you... so this is a good example of where you can relate the anatomy of the brain and the symptoms people are likely to suffer from, and even predict them potentially by going back and asking patients the sorts of questions that we did there. So these sorts of principles are going to be useful for 2 or 3 main reasons. We're going to be able to identify disease mechanisms, and you saw an example there where we can attribute it to a part of the brain, and we know that if patients have that part of the brain involved, for example, in that case, sexual function will be impaired. We'll be able to address the right clinic questions. So by that I mean doctors and health professionals often think the questions they're asking are the most important questions. But in fact, what matters to a doctor might, of course, not matter to a patient, and perhaps more importantly, vice versa. And then we're going to be able to, in clinical trials, measure the things that matter most to really allow us to understand whether the drugs work or don't. You've seen this graph already. So this graph is, again, the example of how patients improve with immune therapies. And indeed, patients with autoimmune encephalitis do improve with immune therapies and often improve quite dramatically. But they do develop a number of side effects on these immune therapies. And in fact, this is a study of 100 patients, and you'll see over half of the patients notice side effects. Now, some of the side effects were relatively mild, but many were quite prominent. So mood change was common, but also quite disturbing sometimes. Patients had muscle problems, they developed diabetes, often due to the steroids. One patient died because they had a fulminant infection. So the immune therapies will suppress your immune system and sometimes allow infections to occur. And so we really need better treatments, not only to improve these outcomes further, but to reduce these side effects. So I'm going to give you an example of how we did that. Actually, I'm going to skip this slide. I've already told you that the plasma cells are the cells that make the autoantibodies. Plasma cells have 2 characteristics. First of all, they're made from B cells. They arise from B cells. You might have heard about B cells. But the 2 characteristics that are really important is they have very few markers. So we have very few drugs which can target their markers. And also they're hidden away. So the plasma cells aren't in your blood, where, of course, most drugs are infused into. They're hidden away in your bone marrow. We can't actually study them because they're hidden away. So they're very difficult to go and capture and understand any better. And of course, what we'd really want to do is be able to eliminate the plasma cells to be able to eliminate the autoantibodies they make. And so I'll give you an example of how we're starting to do this. So these cells, this is something called a fax plot, and I won't go into it in great detail, but to say what it allows us to do is to look at markers on the surface of the cells. So that defines this population here as B cells, which, remember, are the precursors to plasma cells. And this population now are the plasma cells themselves. You can see there are very, very few in our blood. But over time, and under the right conditions, and I've called them stimuli here, we use stimuli which are essentially endogenous to the immune system, but we reproduce them in the patient's blood cells. You can start to proliferate this plasma cell population, actually derive the plasma cell population ex vivo. So you take someone's blood, they have very few plasma cells at that time, you induce the appropriate stimuli, and you make lots of plasma cells. And once you do that, they can actually derive the autoantibodies from those plasma cells, and then you can go about putting drugs into the system to see if we can eliminate this population and then eliminate the antibodies they've made. So that's an example of how the science is hopefully going to help us understand which drugs might be able to target the plasma cells in the future. And then finally, if I have 3 or 4 minutes, I wanted to show you one example of how we might even use this sort of research to prevent encephalitis. So when we started to see patients with one of these forms of encephalitis, they had this very characteristic seizure, which you'll see twitches of this lady's left arm and left face. You'll see an example there. And these are now becoming very characteristic, and neurologists are recognizing this much better now. And there were two important facts about this. One was that they came before the onset of what many people would call encephalitis. They came before the onset of a full-blown cognitive impairment. And the second was that they preferentially responded to immune therapies over the typical anti-epileptic drugs, which of course, as we heard just in the last talk, are used to suppress seizures typically. So I won't go into the data, but the idea being that we know from previous work that if you have swelling in your temporal lobes, as I showed you before, as you do in encephalitis, you go on to develop a loss of that brain region, and that may be it's very likely to be one of the substrates for the problems that patients have after their illness. So for example here, this is a loss of the area called the hippocampus, and if you lose that, of course, memory is one of the important features that is lost. And so what we've proposed is that if you have these seizures, and this is a patient having a seizure, then perhaps, as we know they come before the encephalitis, if you try and terminate them, if you try and stop those seizures, you might be able to stop the cognitive impairment associated with encephalitis, and you might even be able to stop the long-term damage done to the brain due to that encephalitis. So I hope those three examples illustrate some of the ways in which we're trying to tie in the clinical observations with the laboratory work and try and make it an integrated research area which will hopefully allow us to understand the features of the patients better, so potentially improve recognition, to understand the benefits and the limitations of the treatments that are available, allow mechanisms by which we can start to assess the efficacy of new drugs, and then perhaps even prevent some forms of encephalitis. So I hope that was the 2 minutes.
Okay, well, thanks very much for asking me to talk at this meeting. It's a very interesting group of speakers, and I'm going to take you back now to the hospital and the acute management, really, to tell you about what our research group is doing to help improve patients' outcome when they've had encephalitis. So I'm a children's neurologist, and I work here in Alder Hospital. It's a brand new hospital, only opened in September, but I'm also doing a lot of research in the Liverpool Brain Infections Group, and you've met Tom this morning, who's the director of that group. And I'm going to just talk to you about some of our research projects and outline what we're doing really in this area. So I know you've already been told this morning about what meningoencephalitis is, but I thought I'd just remind you and then explain why these patients get brain injuries and what are the problems faced by families along the way in their journey, and then to think about how can we try and help improve some of these situations. So encephalitis, as you've heard already throughout the day, is inflammation of the brain itself, the brain parenchyma, the medical term for it. So you can have bacterial infections of the brain. Many of these are now preventable with vaccines, the ones in green there. And viruses, we're particularly interested in viruses, herpes simplex virus type 1. The cold sore virus is the commonest type in the UK, but if you lived in different parts of the world, it would be different viruses like West Nile or dengue or Japanese encephalitis. And then you've heard about some of the non-infectious causes from Sarosh, autoimmune causes. And encephalitis can be global, like the picture at the top there, the whole brain involved, or focal, just specific areas of the brain. And of course you could imagine that's going to cause different problems for the patients depending on which parts of the brain are involved. And if the covering of the brain is involved, we call it meningoencephalitis. So that's a term you might hear as well. And it just means that the covering is inflamed as well as the brain substance. And it's really important. So lots of patients come into hospitals in the UK with suspected or proven brain infections. It costs the NHS a fortune, and it particularly costs a fortune if it's missed and the management is poor. We had a lawyer here before. I thought she might be going to talk a little bit about that, but she was talking about education. So we know it's very important because we can treat herpes simplex encephalitis with acyclovir, a specific treatment for it, and also autoimmune cases, which are increasingly being recognised, need a different treatment approach. So this is a nice picture that's been lent to us by one of our clinical fellows, and it just shows how complicated it is for patients to get listened to, who to get advice from, and it would be the same for any sort of acute illness really, but you can see you could phone a GP, you could phone NHS 111, you could go into the hospital, And then eventually, if you do get diagnosed with encephalitis, you may well end up in a hospital like mine, a tertiary hospital. And then there's lots of other agencies that you might get involved with, some of the, like the Encephalitis Society. You may end up needing residential accommodation. Unfortunately, some patients will die as well. So what I'm trying to show with this is there are lots of ways that we could perhaps influence what happens along the way to try and improve the outcome for patients, particularly in the acute setting. So you've heard all day about the problems that patients get when they've had encephalitis, cognitive problems, memory problems, behavioural problems in children, physical problems like cerebral palsy if you're a very young child when you develop encephalitis, swallowing problems, secretion problems. Some of my patients will end up with a tube like this, a feeding tube. They may develop epilepsy. You heard about the patient here at the front from the mum talking about it. Your story mirrors like listening to all my patients in clinic, by the way. It's very powerful to hear parents talking about it. It's very frustrating for them. They may also have hearing problems, if they've had meningitis, or visual problems, or multiples of the above. What causes the damage? Well, inflammation mainly causes the damage for encephalitis, but if you have other types of encephalitis, you may have developed pus that needs draining, or you may have inflammation of the blood vessels, which causes vasculitis. I thought I'd just try and demonstrate what I mean by how we can try and intervene with one of my patients. So this is a 2-year-old boy who I met a few years ago in a peripheral hospital when I was doing a clinic there, and he was 2 years old, and it took 13 days for his diagnosis to be made. So he went to primary care 3 times. He got sent away and was told he had a viral illness. He then went to the hospital, and he sat in hospital for 2 days. Nobody did the lumbar puncture, which is the test needed to look for encephalitis. And then eventually he had a seizure, and then people started to think perhaps there was something more serious than just a viral infection going on. And his parents were really very unhappy when they met me, which is about 3 months later. They said to me, "Why didn't anyone believe us when he was ill? We've got 3 other children, we don't bother the doctor all the time with them. And the lumbar puncture made the diagnosis, so why did it take so long to do one in the first place?" I thought they were pretty reasonable questions, to be honest. And the most important question was, will the delay in treatment be bad for him? And the answer to that is definitely yes. So we have thought about this quite carefully, and we've published quite a lot of work looking at the suboptimal management of patients that come into hospital like this, to really try and think, what could we do to try and improve things so that people get picked up earlier and treatment is better sooner. So what is known to be important in acute management? Well, patients need to have a lumbar puncture, and that's to look at the cerebrospinal fluid. So this is a medical, I've used a few terms here. So CSF is cerebrospinal fluid. It's the fluid that surrounds our brain and spinal cord. And we get at it by doing a lumbar puncture, like this child's having one at the top. And it's a really simple test. It's very cheap. It changes the management. And it may actually tell you the specific diagnosis, so whether it's the specific virus, the specific bacteria. And unfortunately, doctors are a bit reluctant to do them. Imaging and CT scans, again, patients with encephalitis really need to have one. CT scans might miss things, but an MRI, the newer scans, are much more sensitive. They will almost always pick this up. And this is a patient, the scan here at the bottom, who's got herpes encephalitis. And then if they've got herpes encephalitis, they really need to get acyclovir as soon as possible, because we know that early treatment improves the outcome. So some of our early studies showed that only half the children that needed to have a lumbar puncture got one. And then if they did have the fluid taken off, only 2/3 of them had the tests done that were needed to be done. And also in children, acyclovir is often started much more than it should be. So it would be started for children who've got epilepsy or cerebral palsy and they come in with a fever, for example, even in children who've taken an accidental overdose. So we were trying to rationalise what people were doing with this drug. There were similar problems in adults. And this led us to publish these guidelines, and doctors can download these from the Encephalitis Society website. And it also led us as a group to apply for a big grant to try and improve the outcome for patients with encephalitis, and it's called Encef UK. So there's a lot of aims. I won't read them all out, and I think these slides are going to be available afterwards, but there are a lot of different aspects to this programme. In particular, neuropsychological outcomes is very interesting, so we're going to be looking at that in detail in adults. We couldn't get the funding to look at it in children, but I think we are going to start to do that soon. And then there's something called a cluster randomised control trial, which I'll tell you a little bit about as well. When we were setting this study up, we realised that another group in Oxford, Professor Pollard is an infectious diseases paediatrician there, was also had funding to look at meningitis. So we put the two studies together and made a really powerful study. So the paediatric aspect of this study is called CHIMES. That's again just a schema of what the whole programme looks like. Lots of different parts to this study. So CHIMES has just finished. This is the study I've been most involved with as part of this programme. We've recruited 3,000 patients, children who've had either suspected encephalitis or meningitis over about 3 years. So it's a huge number of patients. So we're going to be able to tell a lot. It's the biggest study really that's ever been done to look at the causes of encephalitis and then the outcomes and all sorts of things. And of course we're saving the samples, we've got less scans, and there'll be a huge amount of data to collect and to describe for doctors in the future. I haven't got much time, but I'd just like to tell you about this because this is quite an exciting part of the programme. So we wanted to see if our guideline and our package of care could be improved. So we chose 14 hospitals that got this intervention. They didn't know, the doctors on the front line didn't know they were in a study, but the senior doctors were teaching them about encephalitis. They were making packs available to do the lumbar punctures, various different things. And another 14 hospitals didn't get that. And then what we're going to do is we're going to measure the outcome to see if doing this and trying to train people properly will improve the outcome. So we're just waiting to get the results of that. The other part of this we're doing very interested in is asking patients what it's like to have encephalitis. These are some of the quotes from the Encephalitis Society website. So we've interviewed parents and patients and some of the carers of adults as well who've had encephalitis, 30 in total, 5 were children, and done some narrative interviews with 46 participants. And this is just being published. And there's a lot, it's a huge paper, and I'm sure it will be available as well on the Encephalitis Society website at some stage. But the difficulties experienced by patients and families to gain medical recognition for their initial symptoms really came out. That's something we're very interested in. And also the experiences of inadequate hospital care and inappropriate care environments for these patients. So we're going to revise our guidelines, and we're going to use some of this data that we've got from families to try and improve them really for the future. And also we may go on to do more studies in primary care to try and see if we can get GPs and frontline carers to try and recognise encephalitis sooner. And then just briefly, are there any new treatments? So at the moment that we've just opened a study called Ignite. We've got one slide on that coming, which is actually it's the Oxford group who are the chief investigators, and we're collaborating with them. And we are going to randomise children, it's only in children this, to either receive pooled immunoglobulin when they've had early encephalitis or a placebo, and just try and see if that will help the outcome. So this study is called Ignite. It's literally just open. There are 3 patients so far, but we're aiming to get 300 children into this. And this is a government-funded study. It's a huge study that's being undertaken around the country. Like I said, Oxford are the primary the chief investigators. And then just the last slide I've got really is about steroids. So you've probably all heard about steroids. Steroids are used for lots of different diseases and treatments in medicine, and they have anti-inflammatory properties. So we're interested to know if steroids can be used for patients with herpes simplex encephalitis, and this is going to be in adults. This study is just opening now. And you can see at the top this slide of an MRI scan there to show the inflammation in the brain. It looks much better when they've been given some steroids. So there is some anecdotal evidence that steroids might be helpful. Like I've said, we're just opening this study. Again, our group is the chief investigator for this study. It'll be in adults, and patients will be randomised to receive a short course of steroids when they've got proven herpes simplex encephalitis or a placebo. And we'll see whether that improves the outcome. So that's a summary I had to rush through really because of the lack of time. I want to just say that brain infections, as you know, are a common and serious and expensive problem for the NHS. The long-term outcomes, as you've heard all day, are life-changing. Patients often experience suboptimal management, which definitely affects their outcome. And we hope our work in Liverpool and collaborating with other groups, such as the Oxford team, will raise public and professional awareness and hopefully improve care and outcomes. Thank you.